Have you ever had a trauma patient in a neck brace and thought, do I even touch them? Or maybe you've got an order for spine flexion and extension views, and you were like, wait, we do those? Yeah, you're not alone. Welcome back to Analyze with Casey. Today, we're finishing what we started. In the last episode, we broke down the routine and trauma views for the cervical spine. So if you missed that one, it's linked below in the playlist. Today, we're going deeper. We're locking in motion views for cervical spine, routine trauma, and flexion and extension for thoracic and lumbar. And most importantly, what anatomy actually needs to show up on these images to pass the board or pass inspection. If you're prepping for the ARRT exam, doing your CQR, or just brushing off the cobweb, let's make this simple, practical, and ARRT ready. Let's finish up the cervical spine series by diving into motion views, also known as flexion and extension laterals. These aren't part of the standard trauma set. They're only done after clearance, like after a neck injury, surgery, or if the doctor suspects instability. That could mean things like whiplash, ligament injury, a spinal fusion they're checking on, or maybe just some chronic neck pain that isn't adding up. These views help answer the question, is anything slipping, shifting, or not staying where it should when the patient moves their neck? Flexion view. The setup is similar to a regular lateral C-spine. The patient is upright, side to the image receptor. SID is 72 inches. Standard for laterals because we're trying to reduce magnification and see all 7 vertebrae clearly. The central ray is centered at C4, which is right around the thyroid cartilage or Adam's apple. Now here's what makes it different. You're going to have the patient slowly bring their chin towards their chest. Not a fast movement, not jerky, just a slow, gentle tuck of the chin like they're trying to look down at their own chest. Now, as the tech, you've got a few important jobs to watch for here. Watch their face and posture. If they grimace, freeze up, or say they feel dizzy, stop immediately. Check for fall risk. If they're a little shaky or post-op, don't be afraid to have them sit in a chair with a lateral support board. Explain what you're doing. Tell them you'll take the picture as they hold that position. Then let them return to neutral right after. Now, let's talk about what this view should show. When you're reviewing that flexion image, you want to see all 7 cervical vertebrae from C1 down to C7. Ideally, you'll even catch a bit of the top of T1 if their shoulders are low enough. If the shoulders are too high and block that T1 spot, don't panic. You may need a swimmer's lateral, or try giving them light weights to gently pull the shoulders down if they're cleared and stable. The spinous processes should be spaced apart, almost like an open fan. This spacing tells us the spine is flexing evenly and that the ligaments are doing their job. The posterior vertebral line, also called the posterior spinal line, should still look like a smooth arc. If there's a sudden step off or kink, that could mean instability. Also, make sure the base of the skull and the occiput are aligned with C1. No slipping forward or backward. Here's an ARRT style clue. If they ask which line evaluates alignment in a flexion view, the answer is usually posterior spinal line or spinolaminar line. All right, now let's go the other direction. Same patient, same setup, upright lateral, SID 72 inches, CR still at C4, but this time, instead of looking down, we ask the patient to look up. Again, low and gentle. You're not asking them to crank their head back like a dolphin, just a calm, confident tilt of the chin upward. Check their balance. Have them hold the wall or stand, or keep your hand ready to steady them. What should you see? Again, C1 through C7, the spinous processes should now be closer together, also called approximated. The posterior spinal line should still look clean, no step-offs or jagged edges. The vertebral bodies should stay stacked with no forward slipping of one over the next. What you're really watching for here is something called subluxation or listhesis. That's when a vertebra flips out of place. In extension, you'll sometimes catch things that look normal in neutral position. Here's another ARRT tip. They might ask, why are flexion and extension views important in post-op imaging? Your answer is they help detect non-fusion or instability, especially when evaluating for surgical success or ligament damage. Here's some key takeaways. Flexion and extension views are not done during trauma. Always check the patient's stability, comfort, and balance. Know your anatomy, C1 to T1, spinous processes, posterior alignment lines, and if anything looks off, mark it clearly and alert the radiologist. These motion views may look simple, but they're some of the most valuable tools we have for seeing problems that only show up when the spine moves. And that's exactly what makes them board-worthy and real-life critical. All right, time to talk about the thoracic spine, your mid-back. This is your rib cage zone. It's the most rigid section of the spine. Thanks to the ribs attaching to each vertebra, that rigidity makes a little easier to image, but a little trickier when it comes to getting full coverage from top to bottom. We're going to cover 3 views here: the AP thoracic, the lateral thoracic, and the swimmer's view, which helps us see that tricky C7, T1 junction. Let's start with the AP. For this view, the patient is usually lying supine, flat on their back. Your SID is 40 inches, which is pretty standard for any non-upright view where magnification isn't a major concern. You're going to center your beam to T7, which is about 3 to 4 inches below the jugular notch, or right at the bottom of the scapula if you're feeling for landmarks, and don't forget to collimate wisely. We want to include from C7 to L1. We don't clip the top or the bottom of the thoracic spine. Now here's a pro tip that helps with image quality. Use the anode heel effect. That means positioning the cathode side of the X-ray tube toward the patient's lower back, where the body is thicker, and the anode side toward the upper thoracic region, where the body is thinner. This naturally evens out exposure from top to bottom. And if you're working with a fixed table or can't flip the tube, just know you might need to manually adjust your technique or use a wedge filter to avoid blowing out the upper thoracic vertebrae with too much exposure. Here's the anatomy to visualize in the APT spine. All 12 thoracic vertebrae from T1 down to T12. The vertebral bodies should be clearly seen with intervertebral disc spaces visible, although some of these may partially overlap due to natural kyphosis in this part of the spine. The spinous processes should line up in the middle of the image. If they're rotated off-center, your patient might not have been lying straight. Ribs should appear symmetrical and evenly spaced on both sides. There should be no distortion of the heart or mediastinum. If that anatomy is overlapping badly, your patient might have been rotated. Here's an ARRT clue. If the question says your AP thoracic image shows poor visibility in the upper vertebra, but you're within collimation, the best answer is likely to use a compensating filter or adjust exposure time. All right, lateral thoracic spine. Now let's move to the lateral view. This one can be done upright or in the left lateral decubitus position, depending on whether the patient can stand. You'll want them in a true lateral with their arms forward and their spine straight. Watch for kyphosis. The central ray stays at T7, just like in the AP. Now here's the thing. Getting a good lateral of the thoracic spine can be tough. You've got lung, ribs, and sometimes breasts or adipose tissue in the way. That's why we often use a breathing technique. What's a breathing technique? You set a long exposure time, like 2 to 3 seconds, and ask the patient to breathe gently in and out. This blurs out the lungs and ribs, but keeps the spine sharp because it doesn't move as much. If the patient can't cooperate with that, go with a standard exposure and have them hold their breath on expiration to lower the diaphragm and reduce motion. The anatomy to visualize in the lateral T spine. You want to see T1 through T12 vertebral body. You want to see intervertebral disc spaces, ideally open and not compressed by positioning. Posterior ribs should be not doubled. If they're not, you're probably rotated. You may catch a glimpse of the intervertebral foramina, especially in the lower thoracic spine. ARRT style tip. If the question asks when to use a breathing technique, the answer is to blur overlying structures while enhancing spine visibility, especially in thoracic spine laterals. The swimmer's view, C7 to T1 junction. Okay, so what if you do your lateral and surprise you can't see T1? It happens all the time, especially with muscular patients. That's when we go to the swimmer's view. Here's how it works. One arm goes up close to the IR, the opposite arm goes down and slightly posterior. The patient is still in a lateral position. The CR is centered to the C7-T1 junction, right at the base of the neck and top of the back. This position separates the shoulders just enough to see through the dense area of the thoracic inlet. The anatomy to visualize in the swimmer's view. You want to see C5 through T3 are often visible, but we mainly want C7 through T1. No overlap of the humeral head, the spinous processes, and disc spaces at that junction. Good contrast between bone and soft tissue. Through use appropriate technique. Why is this important? This view is critical in trauma. T might miss a small subluxation or instability right at C7-T1, especially if the patient's arms are down during the scan. ARRT style hint. If you can't see T1 on a standard lateral C-spine or T-spine view, the swimmer's view is your go-to. If the test asks what makes the swimmers work, the answer is arm separation to move the humeral heads out of the field. So those are your 3 thoracic spine views. AP for structure and symmetry, lateral for disc spaces and alignment, swimmers to rescue the elusive C7-T1 zone. Don't rush these. Thoracic imaging might not feel as urgent as trauma C-spines or L-spine spot views, but there's so much valuable information hiding in the mid-back. Coming up next, we hit trauma adaptations and flexion extension views for T-spine. For the AP trauma thoracic spine, we want the patient supine, the IR under the patient, and the CR is horizontal at T7. For cross-table lateral, the patient will be supine, and the beam would be horizontal with the IR placed beside or behind the patient. The anatomy to visualize on both of these views is all 12 thoracic vertebrae, spinous process alignment, posterior vertebral body margins. Even if they're heading to CT, X-rays catch alignment issues early and are safer for portable checks. All right, this next set of views is kind of like a unicorn in clinical practice, not because they're magical, but because they're rare. Let's talk about thoracic spine flexion and extension views. Now, I know these aren't something you're doing every day. If a spine surgeon wants to check a post-op fusion site, or if there's a concern about upper back stiffness or instability, these can be ordered. They're also fair game on your ARRT boards or CQR assessment. So let's break down how they work, when and why you'd use these. These are motion views, just like in the cervical or lumbar spine. But the key difference here is the thoracic spine doesn't move much. It's anchored by the rib cage, so flexion and extension here are pretty limited. That means we're not looking for big motion, we're looking for abnormal motion, flippage, instability, or failed fusion. These are typically ordered after surgery or for people with fusion hardware placed in the upper or mid-back. Here's what the positioning setup looks like. Your patient should be upright, either standing or seated against a wall bucky or upright board. If they're unsteady, have them sit. Safety always comes first. Your SID is 40 inches. The central ray goes to T7, which again is about 3 to 4 inches below the jugular notch or right around the mid-scapula level. You'll take 2 images, one in flexion and one in extension. Let's walk through them. For the flexion view, ask the patient to cross their arms over their chest if standing, then gently bend forward through the mid-back, not the neck, not the waist. You're aiming to isolate movement in the thoracic spine, even if it's subtle. As the tech, watch their posture. You want to avoid them bending too much at the lumbar spine or hips. Guide them with your hands if needed to get the right curve. Once they're in position, hold it, take the exposure. Extension view. Now to neutral. For extension, you're going to use same arm position or hands on hips. Ask them to gently lean backward, not from the lower back, but again, focus on mid-thoracic extension. It helps to say, lift your chest up and out, or open your chest toward the ceiling. Be close by in case they lose balance. It doesn't take much. Take your exposure once they're stable. Here's the anatomy to visualize in both views. T1 through T12, all thoracic vertebrae, should be visualized. Look for any angular movement between vertebrae. Spinous processes and lamina should stay aligned. The vertebral bodies should maintain their height and shape. Check for step-off, wedging, or hardware movement if they've had surgery. This is a great view to evaluate healing or failure of spinal fusion, early signs of kyphosis or vertebral collapse, or unexpected hypermobility between segments. A lot of newer techs see minimal movement and think they did something wrong. Here's an ARRT board tip. The thoracic spine is meant to be stable, not flexible. So a minimal difference between flexion and extension is normal. What matters is whether the vertebrae stay aligned or if one slips forward or backward. The board might ask something like, why would a radiologist order thoracic flexion and extension views post-op? And your answer would be to assess for fusion integrity or detect segmental instability. So yeah, these aren't your everyday views, but when they're ordered, they matter. Just remember, good upright positioning, elevate wisely to include the entire thoracic spine, and don't expect major motion. You're looking for anything unusual, not dramatic changes. Next up, we move on to the lumbar spine theory, where motion views are a lot more common and a lot more dramatic. All right, time to head south and finish strong. Let's break down the lumbar spine. This is your lower back, and it gets a ton of attention in radiology. Whether it's for back pain, disc issues, scoliosis, or post-op fusion checks, the L-spine is the moneymaker of spine imaging. We're going to walk through AP lumbar, lateral lumbar, L5-S1 spot, aka the lumbosacral junction view, and the obliques with the classic Scotty dog appearance. Let's start with the AP. The AP lumbar spine. Start with your patient supine, lying flat on their back. Your central ray goes to the iliac crest, which is roughly at the L4, L5 level. Use a 40-inch SID, and here's a pro tip. Have them bend their knees up slightly or put a cushion under them to help flatten the lumbar curve. That reduces lordosis and helps the vertebrae lie parallel to the table. If you skip this, their back arches off the table, your image may be distorted or have foreshortening. Here's the anatomy to visualize in the APL spine. L1 through L5 vertebral bodies, open intervertebral disc spaces. They should look even and consistent. Transverse processes sticking out laterally, sacrum and SI joints at the bottom of your image. Vertebral bodies should be aligned down the midline, no rotation or tilting. Here's an ARRT clue. If you get a question about what landmark helped center the APL spine, remember, iliac crest equals L4, L5. Next up is the lateral view, which gives you the best look at disc space height, spinal alignment, compression fractures, and degenerative changes like narrowing or listhesis. Have your patient turn on their left side into a true lateral position. Bend the knees, stack the hip, and use a sponge under the waist to get the spine straight. Most patients curve downward at the waist, so the sponge helps keep everything in a flat, horizontal line. The CR is still at the iliac crest, and your SID is 40 inches again. Here's the anatomy to visualize in the lateral L spine. L1 to L5 vertebral bodies. You should see the bodies well separated and square, open intervertebral disc spaces. If they're compressed, check your positioning. Spinous processes lined up in profile, and check both the anterior and posterior vertebral body lines. They should form smooth curves with no step-offs. If the posterior margins are misaligned, that's a red flag for spondylolisthesis. Here's an ARRT style tip. They love asking about alignment lines in lateral spine views. Know your 3-column theory and where to check for slippage. All right, the L5-S1 spot view, the lumbarosacral junction. Let's zoom in. Sometimes your standard lateral doesn't give you a great view of the L5-S1 disc space, especially if the patient has a wide pelvis or lots of soft tissue. So we do the spot view, also known as the lumbosacral junction view. Here's the setup. Start with a left lateral position. Your CR is angled 5 to 8 degrees cotted, usually more for females due to pelvic tilt. Center the beam 2 inches posterior to the ASIF and 1.5 inches inferior to the iliac crest. Elevate down. This is a zoomed in shot. The anatomy to visualize in the L5-S1 spot view. You want to see L5 vertebral body, S1 and the sacral premonitory, the L5-S1 intervertebral disc space. This is your target. Make sure there's no overlap from iliac wings or soft tissue. Here's an ARRT clue. This view is key for evaluating spondylolisthesis when L5 flips over S1. So don't be surprised if you see a test question asking which view best demonstrates that junction. This is the one. Okay, last in the routine series, we've got the obliques. These are usually ordered when there's suspicion of facet joint arthritis, pars defects, or spondylosis. They're also your Scotty dog views, a favorite on the board. Here's how you do it. Rotate the patient 45 degrees. Posterior obliques, LPO and RPO are your most common. Your CR is centered to L3, which is about 2 inches above the iliac crest. Posterior obliques show the downside zygapophyseal joint, the ones closest to the table, while anterior obliques show the upside. Here's the anatomy to visualize in the oblique L spine. This is where the Scotty dog makes an appearance. Here's how to read the anatomy. The eye is the pedicle, the neck is the pars interarticularis, the body is the lamina, and the ear is the superior articular process. The front leg is the inferior articular process. If the neck, or pars, looks broken or appears as a dark line, that's called a collar. That's called a collar on the Scotty dog, and it may indicate a pars defect or spondylosis. The ARRT loves to ask, which view best demonstrates the Scotty dog sign? The answer is the oblique lumbar spine. All right, now let's shift gears and talk about the trauma lumbar spine series. You've got a patient who's been in a car crash, or maybe they fell from a ladder, and you get the order. Lumbar spine trauma protocol. Let's talk through how we approach this safely and how to get the images the trauma team actually needs without risking your patient. Positioning principles first. Just like with the thoracic trauma series, the number one rule is this: don't move the patient unless they've been cleared by the trauma team or neurosurgery. So everything you're going to do here, especially your lateral view, has to be done with the patient lying flat on their back, exactly how they arrived. We use cross-table technique with a horizontal beam and place the IR either behind the patient or underneath of them if you're using a stretcher tray or a mobile x-ray unit. Here's your standard trauma protocol. Cross-table lateral. This is your first and most important view. It gives you a quick side-on look at vertebral alignment, potential fractures, or your supine AP. For this view, the patient is still on the back, no rolling, you center to the iliac crest, same as in the routine lumbar. Usually the L5-S1 spot view is optional. If you can safely get it, especially if the trauma is low or you suspect spondylolisthesis. You won't always get the spot view in trauma if the patient's in too much pain or can't tolerate any angling or extra views, but when you can, it adds a lot of value. Here's the anatomy to visualize in the trauma L-spine views. Let's go view by view. Your cross-table lateral, L1 through L5, ideally visualized in full, and your L5 through S1, if you can get it, though it's tough without moving the patient. You want to assess the alignment of vertebral bodies from top to bottom. Look at the anterior, midline, and posterior vertebral lines. They should form smooth, continuous curves. If there's a step off, misalignment, or widening of disc spaces, that could indicate fracture, dislocation, or instability. Also, check the spinous processes. Are any of them widened or fractured? That could be a clue for a flexion injury. Your AP supine view shows vertebral body shape, transverse processes, and pedicles. Watch for rotation. Make sure the spinous processes are centered between pedicles. A widened psoas shadow or blurred transverse process could be a soft tissue clue that something's off. Here's an ARRT tip. If you're asked what you can assess on a trauma AP lumbar, the key answers include fracture lines, transverse process avulsions, and vertebral body compression. Next up is your L5-S1 spot view. This is optional. It's done if you suspect a slip or fracture at the base. Remember, you angle 5 to 8 degrees and center 2 inches posterior to the ASIS and 1.5 inches below the crest. This zooms in on the lumbosacral junction where L5 meets S1. What are you looking for? The L5-S1 disc space, S1's anterior margin to check for listhesis or slippage, and the sacral promontory. This view helps diagnose spondylolisthesis, compression fractures, and posterior element injuries, which are all board-relevant terms. And here's a clinical reality check. Even if a CT scan is ordered next, which it often is, these x-rays still matter. Why? Because your x-rays are what we base immediate care on. Whether the patient can be rolled, whether a brace or collar is needed, or whether emergency neurosurgery should be on standby. So don't think your trauma views are just a formality. They often make or break the next decision in care. Here's a quick recap. In lumbar spine trauma, don't move the patient. Start with a cross-table lateral. Add a supine AP and a spot view if possible. Look for step-offs, fracture lines, and alignment issues. And remember, your images might come before C, but they still drive major decisions. Up next, let's talk about flexion and extension views for the lumbar spine, where things start to move. Motion views are what you'll see ordered as flexion and extension laterals of the lumbar spine. These aren't routine. You'll usually see them ordered after spinal fusion surgery or when the doctor suspects some kind of instability like spondylolisthesis, which is when one vertebra slips forward or backward out of alignment with the one below it. Sometimes patients will come in years after surgery and say, "My back feels like it slips when I bend over." That's when we get these motion views. And for the ARRT, oh yeah, this is the common question zone. The patient's set up for motion views. You'll take 2 images, one in extension. Your patient should be upright, either standing or seated, depending on their balance and mobility. If they're a fall risk or post-op, don't be afraid to do this seated with a stable chair and lateral support. Your SID is 40 inches. Your CR is centered to L3, which is just above the iliac crest. Collimate to include L1 down to S1. You want the whole lumbar spine and sacral base. On the flexion view, ask the patient to cross their arms over their chest. It keeps the arms out of the spine field. Then instruct them to slowly bend forward like they're trying to touch their toes, but only as far as they can. Watch their posture. You want the spine to curve forward, not just their shoulders slumping. Once they're in position, make sure they're stable, then take the exposure. The extension view. You want the patient to go back to neutral and now have them place their hands on their hips, then gently lean backward, opening the front of the body. I like to say push your belly forward and lift your chest. Again, don't overdo it. You're just looking for controlled movement, not a dramatic back bend. Confirm they're steady and upright, and take the image. The anatomy to visualize in both of these views are subtle but powerful. You're not looking for big changes. You're looking for key signs of movement or slippage. Here's what to evaluate. L1 through S1 vertebral alignment you should see all 5 lumbar vertebrae and the top of the sacrum. No vertebra should be slipping forward or backward between views. Spinous processes should remain in a smooth curved line, and flexion and extension they come closer together. If one suddenly looks out of place, that's a clue. Vertebral body shape and height should be consistent. That would suggest that there's no compression fractures. Interspinous spacing and flexion, spaces widen as the spine bends, and extension, spaces narrow. If spacing looks uneven, that might indicate segmental instability. Posterior vertebral line should remain smooth and unbroken. A step off could mean spondylolisthesis or failed fusion. Here's an ARRT clue. They might ask something like, what's the purpose of lumbar spine flexion and extension views? The answer is to assess for instability or fusion site motion. Or what anatomical changes is expected in extension? The answer is the spinous processes approximate and the lumbar curve increases. Here's some safety reminders. If the patient says they feel pain, tingling, or instability during movement, stop immediately. Don't push through resistance. These are diagnostic tests, not physical therapy exercises. If there's hardware in place like rods or pedicle screws, be extra cautious. These images can reveal if things are shifting around the fusion. All right, let's recap your lumbar motion views. They're typically ordered post-op or when instability is suspected. You're looking for subtle shifts, abnormal motion, and failed fusions. Your setup stays consistent. L3 centered, 40-inch SID, and L1S1 collimation. Flexion should show widening, extension should show narrowing, but both should keep a smooth, continuous alignment. These might not be everyday images, but when you can get them, they carry serious weight. Coming up next, we're wrapping up the full spine series with a final review and quiz, so stay with me. Before we close out, let's hit you with a quick pop quiz to test what you remember. Don't worry, this isn't graded, but it'll help lock it in. Are you ready? Let's go. Question 1. Which lumbar view is best for visualizing spondylolisthesis at the L5-S1 junction? A. Lateral lumbar, B. AP lumbar, C. Oblique lumbar, or D. L5-S1 spot view? The answer is D, the L5-S1 spot view. That cone-down, angled view shows the lumbosacral junction in detail and is your go-to for spotting slippage. Question 2. In a lumbar oblique view, the neck of the Scotty dog represents which structure? A. Transverse process, B. Spinous process, C. Pars interarticularis, or D. Pedicle? Our answer is C. Pars interarticularis. And if it looks like it's wearing a collar, that's a potential pars defect. Question 3. Why do we use the breathing technique in lateral thoracic spine imaging? A. To reduce scatter, B. To blur the ribs and lung detail, C. To increase contrast, or D. To visualize spinous processes better? Our answer is B. To blur out the ribs and lung marking. That way the vertebra stays sharp while the rest gets smoothed out. Question 4. In a lateral flexion view of the cervical spine, what does increased spacing between spinous processes indicate? A. Good flexibility, B. Ligament instability, C. Fusion failure, or D. Normal kyphosis? Our answer is B. Ligament instability. That widening can be a red flag, especially if it's uneven. All right, Rad fam, take a breath. You just made it through an entire spine imaging masterclass. We covered a lot. Let's bring it all together with the big takeaways. First, know your setups. Whether it's routine, trauma, or motion views, you have to know your patient position, SID, CR, and when to adapt based on condition or mobility. Second, know your anatomy. Don't just aim for good enough. Learn what structures each view is supposed to show so you know when to repeat, when to adjust, and when it's diagnostic. And third, always protect your patient, whether that's with shielding, clear instruction, or just knowing when not to move someone in trauma. You're the first line of defense in that room. Let's do a quick recap of key points. Flexion and extension views, whether cervical, thoracic, or lumbar, are about spotting hidden instability, especially post-op or post-trauma. They're subtle, but they matter. Don't skip the anatomy evaluation. Just because you got the shot doesn't mean it's diagnostic. Learn what each image should show and how to identify rotation, step-offs, or poor visualization. Center correctly, collimate carefully, and don't forget the little things like patient comfort, labeling, and breathing instructions. These small details, they're what separate a good tech from a great one. And hey, if you haven't grabbed it yet, I've got a free spine imaging cheat sheet linked below. It breaks down the anatomy you should see, the CR and SID you need, and how to evaluate if the image is good enough or needs a redo. Print it, annotate it, tape it to your wall, share it with your classmates or coworkers. That's what it's there for. And finally, if you've made it this far in the video, I just want to say I'm proud of you. This content is dense, it's technical, it's easy to feel overwhelmed or second guess yourself. But you showed up, you followed through, and that tells me you care about being the kind of tech patients can count on. So, whether you're prepping for the ARRT, reviewing for your CQR, or just sharpening your skills after a break, keep going. You've got this. I'll see you next Wednesday, same time, same place for our next imaging breakdown. And don't forget to like, subscribe, and comment below. Which spine view you still feel unsure about? Let's keep learning together.